obviously I'm gonna come with the caveat that I come with this sort of not from just a emergency background, more of a critical care background, because unfortunately or fortunately, I have to deal with the patients after they're intubated. And I trust me, I know all residents love intubations. Okay, like your indication intubate is like have an airway, I can intubate, right? So trust me, I was a resident too. At one point, I'm like, I want to intubate every single person that I can, right? Then it's like, okay, then only afterwards, like, oh wait, should we have actually intubated that person? Was it really indicated? All right. So as always, I have no financial disclosures, unfortunately. All right. So again, you guys, I know actually at this point, you probably actually how many people actually when was the last time somebody actually used a direct raise hands? Okay. Really? The last one you did, it was direct, not video. No, 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 no. How many was last direct, not video? Okay, yeah. So I should really change that picture nowadays, actually. All right. So you so to try and figure out like when exactly do you want to put the plastic tube in there and when do you not need to, right? So first things first, we're going to discuss the indications intubation. So what are the indications for intubation? Hmm? Failure to protect, which every one of you guys love to have failure because it is so subjective. We'll talk about that last. Sure, failure to oxygenate. What else? That is failure to, that's an inability to protect, right? GCS is essentially because, oh, you don't think you can protect airway, right? And I'll discuss a little bit of that later again. Next, which is also called failure to, thank you. All right, so failure to oxygenate, failure to ventilate, and failure to protect airway. Okay, we'll talk about each one of these. There's actually a couple other reasons, but we'll talk about these main ones first. Okay, so failure to oxygenate, right? So you have to figure out what exactly are you trying to do when you're trying to intubate the patient. How are you going to improve the patient's oxygenation? What are you trying to do? Why? So what if you intubate? What is it that you're providing them that you cannot provide otherwise? Okay, so you want us, your goal is to give oxygen supplementation, right? And the other one I heard is that you want to do positive pressure, which, yeah, sure, positive pressure. What we really want is actually people to recruit the alveoli, right? Those are the things that you want to do. That's how you're going to improve the patient's oxygenation, okay? Now, so the good news is that like I'm not going to go too much into all the different causes of deoxygenation. Essentially, what you need to know is actually anybody who's above 5 liters or 40% FiO2, you can essentially eliminate everything of VQ mismatch, everything else. The only thing you have to think about at that point is actually shunt physiology, okay? So I know that you guys probably listen to lectures like, oh, this is how you treat like VQ mismatch and hypo. Don't worry about that stuff, okay? The two to the left, all those go away as soon as you have FiO2 above 40%. Okay, and assuming the patient is breathing. If they're not breathing, meaning 0 breaths, that's a completely different other issue, right? But if they're breathing, even if they're hypoventilating, even if they're breathing 4 breaths a minute, as long as you have FiO2 above 40%, it's no longer the problem. Once you're above 40%, once you get above 5 liters, now you have to think shunt physiology, right? And the only way to solve the shunt physiology is to recruit alveoli, all right? So there's a little bit of a clearer picture, right? So obviously, the alveolar on the right is the one that's open. It's actually open for gas exchange. The problem with the alveoli on the left, when it's collapsed, is that when it's actually when the blood goes from the right side of heart to left side of heart without going through any kind of gas exchange. Okay, and that's what you're trying to do with partial pressure ventilation, right? Again, not partial ventilation as in like bag every single breath. Is to say when you after breath comes out, the alveoli stays open for gas exchange. Does that make sense to everyone? Okay. All right. So the next thing is that you have to really think about it. How likely is this person actually going to actually recover? Okay. Now, what I mean by that is how quickly recover, because the person on the left, okay, if they have a mucus plug, if they have huge pleural effusion, that is something I can do something about that without having to intubate the patient. Chest PT, and yes, there are many cases of where James. Oh, okay. All right. So when when you do overnight critical care, it will happen many times. So they're going to call you on the floor, like, hey, this patient is desaturating. You see the chest X-ray. Oh my God, left side or right side. used to be okay, actually looks horrible. You're like, all right, well, I'm going to take the patient to the ICU, we're going to intubate the patient, I'm going to bronch the patient. And you're like, all right, you know what? On the way, tell him him or her to cough as much as possible, hit on the chest as much as possible. And there's actually a good percentage that by the time they get to the ICU, like, yeah, they just coughed up something. Now it's actually saturating 98%. I'm like, okay, downgrade immediately. Just kidding. Right. So like this is something that you can solve very quickly, right? And the other problem is that with the mucus plug and with the pleural effusion, will positive pressure ventilation change anything? Right, because what's the issue? The issue is that there's something compressing or not allowing air exchange that the positive pressure will not do anything about, okay? Positive pressure ventilation only helps when you actually recruit the alveoli, okay? Now, so those are the cases where I'm like, okay, all right, yes, they're not saturating well. Yes, you're giving 100% FI, sorry, 100% non-rebreather on top of 40 liters on the high flow nasal cannula, and they're still setting 85%. Well, the answer is because you cannot recruit enough. You can put a PEEP of 20, 30, it does not matter, right? You will not solve that issue. Right. However, those are the ones that I can actually do something very quickly about. If I can put in a chest tube, if I not forget chest tube, I can just put a needle catheter in there and just strain even a couple hundred cc's pleural effusion, that will solve the issue. If there's an actual mucus plug, if I make this person aggressive chest PT, cough it up, I don't need to actually intubate the patient. Does that make sense? Okay. Versus, I would say the person on the right, this is the multifocal pneumonia, or at least that's what it looks like to me, right? This is not going to resolve any quickly, right? So like, so if you see that and you're saying like, okay, this is a person that I know that I cannot resolve very quickly, then this is the person I'm like, yeah, probably will need to intubate. Now, obviously, we'll go back a little later. Now, next one is going to be failure to ventilate. All right, so I know that most of you guys failure to ventilate. When I say failure to ventilate, what's the number one thing you guys think about? COPD and asthma, right? And I really, really hope that very, very few of you have actually ever intubated a COPD asthmatic, because a lot of those should not need to be intubation, okay? The ones that I really think about more often than that is actually obesity hypoventilation syndrome, right? And the zero or near zero ventilation, and then the chest wall diaphragmatic failure. And I'll talk about each one. Okay, obesity hypoventilation syndrome, and you've seen these patients. Actually, yeah, I'm pretty sure you have. Especially with the American obesity. So like a person comes in, right? They live because of the obesity hypoventilation, they live with CO2 55, 60, right? And has nothing wrong. There's nothing wrong with their lungs. They're not smoker, or maybe they at least not smoke long enough to actually affect their chronic COPD. These are patients because of their obesity, they're just not breathing as much. So they start living at the 50, 55 range, okay? And then what happens, unfortunately, is that sometimes they actually get a little bit worse, the mental status gets worse, which means they breathe less, and then just a spiral, right? And those are patients that I need to actually improve the ventilation so I can get rid of CO2, the mental status improves. What do I mean by zero near zero ventilation? Essentially, opiate overdose or anything that causes non-breathing that's not opioid. Because again, opioid is one of those things that we can reverse very, very quickly. Not a reason to intubate somebody because they're opioid overdose, right? But if somebody who has a cause that is non-reversible, that patient is not breathing at all, okay? And I don't mean cardiac arrest. I mean somebody who's, for example, severe brain injury, that's a person that actually either traumatic or non-traumatic that's caused the patient no longer breathe, or some kind of stroke, Undine's curse, all that. Okay, and lastly, what do I mean by chest wall and diaphragmatic failure? Okay, so what's the definition of flail chest? Okay, one person speak up. Okay, yes. So essentially, the chest wall doesn't come out, right? So, and what I mean by this is, I know a lot of people like, the definition of flail chest is how many refractures on CT X-ray. That's a radiographic definition. Okay, what we care about is actually physiologic definition, right? Which means is when we breathe in, the chest wall goes out, the diaphragm goes down, right? So anything the thing that does cause that not to happen means that this person has what I call chest wall diaphragmatic failure, right? Again, this flail chest, the most common is a fracture. We say, well, chest wall is supposed to coming out so to expand your lungs. If you do not have the ability anymore because you have so many fractures, well, guess what? You're no longer expanding your lungs, because you cannot expand your lungs with just the fact it's just your diaphragm alone, okay? Or at least not from right now. You can eventually learn to sort of people who have severe injuries, but usually you still have a lot to learn about that. to redo that. Your brain has. The other, obviously, you said if you have some kind of diaphragmatic injury, a phrenic nerve injury, diaphragmatic rupture of traumatic or non-traumatic, those could also cause the fact that you no longer have the ability to actually increase the negative the space within your chest when you have negative pressure. Okay. Now, so those would cause a failure to ventilate. Okay. And then the last thing is reactive airway disease, what we call it the COPD asthmatics. Okay. Now, again, what is your goal of intubation? What do you want to do with the goal of intubation? Okay, so you assist the tidal volume tidal generation, right? So people who have obesity hypoventilation is usually because, yes, they're still breathing. It's just that they don't breathe very, very well, right? They're like, instead of having like 500, 600 tidal volumes, they're breathing some 200 tidal volumes. All right. Other times you're forcing it entirely because they're not breathing at all, and you just have to force a tidal volume generation to begin with. And then finally, obviously, increase respiratory rate. Right. All of this to increase your minute ventilation and to clear carbon dioxide. All right. Which goes back to comes back to this. Everything that we described can actually be facilitated without intubating the patient, right? With non-invasive partial pressure ventilation, right? And for those of you who worked with me enough, you guys already at this point know that I hate when you guys tell me 10/5 for everyone. And then you try to be cute when I give you the look and you're like, oh, no, I mean 12/6, right? Because there's a huge difference in those two, right? So having said that, what are the three numbers for non-invasive? When you call it respiratory, say, hey, I want a non-invasive, I want BiPAP, I want CPAP. What are the three numbers you should be telling them? These are the numbers I care about. Oh, sorry, what three numbers you said? And then what's the number you should actually care about in each specific case? Okay, you answered before. Okay, so PEEP, go on. Or expiratory pressure. FiO2, true for everything, go on. And then what's the other one? Nope, you do not set the tidal volume in non-invasives. Yes, I know you guys have AVAPS mode. AVAPS mode is only available on certain proprietary software, so therefore it's not available for pretty much most of the software out there. Okay, just so you know. Inspiratory pressure, right? So it's the same thing as if you actually think about when you actually think about the numbers, is when you actually bagging a patient, right? When you give the breath, that's your inspiratory pressure, right? The flow of oxygen to your valve, that's how much FiO2 you're giving. And then if you have a PEEP valve, that's your expiratory pressure, right? You're essentially doing the same thing, except that you're using the machine to do it, okay? So what do you want it to PEEP for? At what point do you want to use the PEEP? What is important? Why do you care about the PEEP? At what circumstances? When you failure to oxygenate, right? This person, you need to recruit the alveoli, okay? Now, when you care about the inspiratory pressure, right? So when we want to ventilate the patient properly, right? Because if you see on a machine and say, hey, and I cover up all the numbers for you, and you see that the patient is volume is only 200, your answer is like, well, whatever the expiratory pressure is, increase it. Okay, because you need generate bigger tidal volume. Does that make sense? Right? If you're having problem with oxygenating, the answer is obviously go FiO2. But then you also say, can I recruit more alveoli? Right? Again, what I tell you is that shunt physiology after 40. Oh, bless you. After 40%, shunt physiology, the only thing explanation. Now you need higher peak to recruit the alveoli. Okay, and that's assuming it's recruitable. Any questions so far? Okay. Yeah.
So that icon
No.
okay, that pressure.
Yes.
That becomes the icon, yeah.
No, because some people go like this. Other people go. So it depends on the patient. It's on how well the flow, like you said, it'll flow through. That is the sensor. You can sort of play around with the flow sensor, but it's not something I actually want you guys ever play around with. Like it's not. You can actually screw it up a little bit. So, huh?
What would be that?
You mean the AVAPs or the actual? Yeah, but I wouldn't want you to try to do that too much. It's not something you should play around too much. Anything else?
My understanding is that help ventilate obstructive lung disease, then goal is shorten icon and maximize time so you can get off air. And you can't put the icon on bypass and talk a little bit about how to ventilate obstructive lung disease.
Oh, that's part of my vent talk. But sure. Okay. So I'm gonna go through real quick. Okay. And for some of you guys have actually talked. I've actually talked about this. All right. So you're talking about after you intubated a patient who intubated a patient, right? Or you-
It might be another 20 hours.
No. I don't set the eye time when the patient is non-invasive because the patient is determining how long the breath is going to be because they are determining that breath, right? So I do not set that at all. Okay. And I actually don't like AVAPs very much either. But that's a little more longer talk about why I don't like it. I set what I think is the appropriate tidal volume, okay? Because when the patient determines to take the next breath is when the patient determines the next breath. As I don't set that time unless the patient's breathing forward, then I'm like, no, I'm going to determine that you have to take a breath sooner than that. Okay, that's a different question. Any questions? All right. So this is the your favorite reason. Wait, hold on. Right, sorry. So again, failure to oxygenate. So and so when do I actually intubate the patient, right? So failure to oxygenate despite non-pressure, positive pressure, non-invasive positive pressure ventilation, right? And the answer is for me, a lot of times it's like, it really depends. But for me, some of the call off is like, if you're on 75% and people 10 and you're still saturating less than 95%, even if you're looking somewhat okay, 92%, I'm probably going to intubate you. The reason is unless I can reverse very quickly. For example, if it's a pneumothorax, yeah, I'm not intubating you just so I can resolve the pneumothorax. If it's a non-reversible reason, for example, the multifocal pneumonia, the chances are this person's probably get worse. And I prefer not to intubate somebody who's on FiO2 100% and saturating 92%. That's not somewhere I want to be. Okay, does that make sense? All right. It's more now. Have I gotten away with sometimes? Yes, but it's very you always want to be intubating at the safest circumstance. Okay. Now, again, I'm sure at this point you guys have all seen escape. This patient comes in at 68%. You put on non-breather. They're like, sorry, non-invasive, start to nitro, and you're like, man, this person's only satting 82%, and you're like, I might have to intubate the person, but it's like, no, there's a lot of cases these case route turn around very quickly, right? So you're trying to buy yourself as much time as possible. Versus the person who's febrile pneumonia, setting 92% multifocal pneumonia, I'm like, yeah, this person's not going to get better probably within the next 3 days, and this is probably somebody I would probably intubate earlier than later. Does that make sense? So like the whole failure to oxygenate, it really depends like how well can I actually reverse it quickly? Can I use non-invasive? And how quickly can I reverse? All right, failure to ventilate, pretty much the same thing, right? How well can I actually improve that with non-invasive, right? Now, if you despite the non-invasive, you still have mental status deterioration with worsening CO2, and there's no quick reversal, meaning obviously Narcan or something along those lines, then the patient probably will need intubation at that point, okay? Because obviously the problem is that with non-invasive, despite the fact that you can have a great seal on the face, it is still not the best seal as an endotracheal tube. And the other thing is that it's not a complete closed off airway because you can still air can go through esophagus into esophageal sphincter instead of going down to the airway. Make sense? Okay. All right. So your last and favorite for every single resident is failure to protect airway. And this is pretty much a lot of very subjection. Okay. So everyone loves to say decreased mental status, and I don't really know what that really means these days. Inability to clear secretions, airway, and we'll talk about that. And then finally, physical obstruction and all that stuff. All right, so let me jump to this one. Oh, come on. Oh, here we go. So, oh, shoot, what am I doing? There we go. Yeah, this is the only meme I'll ever make. Okay, so all of you guys at this point, I tell you guys seen enough drunks in your hospital. I'm gonna name some random name: Mr. Lee, Mr. Johnson, Miss whatever, Grothrofty, like those. Well, maybe that's my patient. Anyway, so actually, you've seen patients that use like I've seen this person 3 times this week. Okay, right? Because you know this person, right? And you are all going to be attending one day. You're gonna go to some other place, and you're gonna see some person and be like, oh my God, this person's GCS sucks, right? Like, EMS brings him in, it sucks. And you're like, oh, we got to intubate. And the charge nurse is going to be like, no, please don't intubate. Mr. Parker's been here like 3 times this week. Please don't intubate. And your head to be like, I don't know, maybe we should intubate this patient, right? And I've yet to find out the difference between somebody who's quote unquote intoxicated versus the person who has intracranial pathology, non-traumatic, okay? Pathology said, oh, this person needs intubation, because it is very, very difficult to tell. The reason, next time you guys see the drone that you guys see also, I want you to tell me how is it that you're able to tell the difference in these that patient. The reason you are, because like, yeah, I've personally seen this patient 20 times within the last 6 months. So therefore, no way am I taking an ICU bed for this patient, right? Whereas the other person, you're like, oh, I just never seen before. So you're unsure about that patient. Does that make sense? Right? So it is very, very subjective. And I don't have a good answer for this, except that thankfully there was a recent study, I think it was recent, 6 months, 9 months ago, that came out where they actually studied, they essentially did what most of us have been doing in the ER for the longest time. It's like, all right, these patients that we think is just intoxicated from either from drugs, we didn't intubate most of them and see what happened, and most of them did fine. Okay, so therefore, like there was no reason need to intubate these patients, right? And next question, next scenario that I always tell you is, and I assume most of you guys gone to college or have gone to some kind of frat party or sorority party or whatever, right? And you've seen your friend who's drunk in a corner, right? Who's like, you're like, oh, are they breathing? Oh, I guess they're breathing a little bit. Okay, are you gonna intubate that your friend? Like that's the question. If you're gonna say, yeah, I would intubate my friend. Now, assuming you like this person. If you don't like this person, that's a different question, right? Or if you're gonna say like, I would definitely intubate that person, I'm like, well, then yeah, maybe you shouldn't be a physician anymore, because obviously that's probably not the right move, right? So it is a very subjective definition, and I don't have a good answer for you in that answer for that question. And that's the same thing for a person is, when you say like GCSF8, when you say the person is like, post-ictal, like all those things, like person who has multiple seizures, like, oh, we got to intubate. It's like the reason you're intubating is because like, oh, I think that their ultimate mental status is not protecting airway anymore. And it's really, really hard to prove that one way or the other. Even in neurocritical care, half the time we do is that we extubate the patient and be like, well, let's see if they can actually hold the airway, right? And it's like, and then you watch, oh yeah, well, saturation is starting to go down within 20 minutes. Yeah, okay, fine, they failed. Reintubation, trach, right? That's essentially how we actually able to tell. So if you are able to tell, let me know, because I've yet to figure out how to actually tell the difference in those. All right. Next one is inability to clear secretions, airway. Again, that one's very, very subjective. Yes, if you hear gurgling and you see a chest X-ray and you see pulse ox desaturate, yeah, that's pretty much the person not protecting the airway, right? I'm sure if he's drooling that they say I cannot control my secretion, that's a very, very obvious answer, yes, right? But otherwise, again, it's very, very difficult to even in the ICU. All right. Finally, is the actual failure to protect. What I truly call failure to protect is there's actual physical obstruction, right? So meaning there's a trauma, there's a foreign object, all the angioedemas we see or swelling for chemicals. I mean, when I chemicals, mostly I mean it smoke inhalation. Otherwise, most people don't, inhale hydroxide or something like that, right? And then finally, the infectious causes lung whiz and bronchitis, right? And these are the ones that are also very, very, very subjective, right? I would say if you see vocal cord edema, if you see any kind of airway, you would probably lean towards intubation, right? Now, it's also very, very helpful if you can just like, if you have nobody else in the hospital, right? In the ER, you're like, this is 2 o'clock in the morning, there's nothing happening. I'm like, all right, you can sit on the patient, just watch them, really watch them and see how they either get better, get worse, or no change, right? And if you've seen at this point, how many patients actually have seen angioedema come in and get much worse that you need intubation? Not like from the get-go, but much, much worse. You put your hand down. Right. So it's not that many. And you guys all seen angioedema, right? Right. Like, so you can, the reason is that we just watch them, like and I'm not saying angioedema cannot get worse. They definitely can get worse. It's just that you just have no idea. You're doing one point in time. The best answer for every question we have in medicine is time will tell us whether the person needs intubation or not. Okay. And if you can, multiple scopes, if you can, if the patient say, hey, I feel like my voice is getting worse. I'm like, okay, well, that's pretty much a sign. So it is watching for actual physical worsening of the physical obstruction. Make sense? Okay. All right. So again, we discussed all these. All right. So we're going to go through real quick the 2 other reasons for intubation. Okay. LV failure after load reduction, and the worker breathing and O2 over extraction. Okay. All right. So I'm sorry about this. This is one of the few graphs I have on my lecture, and I try not to put too many of these. All right. So, all right. So very simply, the afterload is the pressure that the LV must exert to expel whatever contents they have in the ventricle. Okay, that's definition of afterload. Okay, whether it's LV, RV, we're going to discuss that a little further. Why it's a little bit important each one. All right. So if you actually have positive pressure ventilation, if you notice that if you have intrapleural pressure of 10, okay, so that's pressing on the left ventricular pressure needed of 90 to open up. So therefore, the ventricle only needs to give 80 of pressure to actually overcome. Okay. Now, I know I'm giving this another analogy for you guys to understand a little bit easier. Imagine all of you guys doing a bench press, okay? And your bench presses, but you're blindfolded, okay? Let's say you all bench pressing at 50 pounds, okay? Now you're just like the heart, you're doing bench press, let's just say 1 every 5 seconds, okay? You're bench pressing, and suddenly somebody else, let's say James, me, whoever else, right, comes around and we lift from the other side. But you're blindfolded, we're lifting from the other side, 10 pounds off of you, okay? Suddenly you feel like, hey, it's much easier for me to push up that weight, right? But did your muscle get any stronger in that instant? No, right? Your muscle's still exactly the same. It just feels much easier. Okay. So therefore, this is why it can help with LV afterload, because the afterload is what the left is what the left ventricle at this point will see, so that you can actually contract, you still expel fluid out of the aortic valve. Okay. So does that make sense? So positive pressure actually helps with LV afterload, or if you have LV contractility issues. Okay. All right. The other reason is that you will ever so often you will see a patient that will come in sitting around 85, sorry, let's say 70%. You give them 95% using non-high flow nasal cannula as well as 100% normal breather, and they're still only sitting 85% or so. The reason is because most of us most of us have hemoglobin. When it comes back, 1 or 2 hemoglobin taken off. So we're somewhere around SCVO2 is around 70%. Every so often that you will have come back at 30%, and what happens is that you will go through the lung so fast. It's nothing to do with the fact that your cardiac output or you don't know how bad it is. It goes through so fast that it doesn't have time to fully oxygenate. It'll come out on the arterial side 85%, which point you're starting off at a worse point. Does that make sense? Right? And it's nothing really to do with the lungs itself. It doesn't happen all that often, but every so often it does happen. Okay. And you'll be like, wait, the chest X-ray doesn't look too bad, or like, oh, this is really small pneumonia. I don't think this is the cause of it, right? And that will be the reason why. The reason is because your body is expending so much of the oxygen that it comes back at 30%. So how do you solve that issue? Well, the issue is that now you have to say, how do I make it so the body expends less oxygen? Right now, all of you guys sitting, you're using about 2 to 3% of your oxygen output and on your breathing. The patients who are in extremis, usually they spend around 35 to 40% of it. Okay. So what you want to do is like, now I'm going to take your breathing completely. And this is one time I'm like, no, not even non-invasive. I don't even want breathing at all. I'm going to take it away completely, because non-invasive, you're still initiating a lot of stuff. I'm just going to take it completely away. So I'll intubate you and I'll make the machine breathe all of it for you, so that you can actually have the oxygen be used elsewhere in the body. Does that make sense? Okay. All right. So again, we'll go with the reason. Failure to oxygenate if a non-invasive fails. Failure to ventilate if non-invasive fails. Failure to protect area, we told you is very subjective. LV afterload reduction, and then work with breathing and CO2 over extraction, okay? Or O2 over extraction. All right, let's talk about intubation contraindications. Anybody have contraindications? I don't think people ever talked about this, right? Okay, fine. Oh, you're right. I did not put that on. Good. Yeah. All right, fine. I did not put that on. Very good. Huh? All right, so pneumothorax bronchopleural fistula. All right, please try not to do this, because again, will your intubation solve the issue? Probably will make it a little bit worse, right? Yes. If you have a pneumothorax, you should not intubate because you'll make the pneumothorax worse. Yes or no? Say yes, raise your hand. Say no, raise your hand. Really? Unfortunately, the no win. It's only actually, and it depends on the study. You say any 10 to 40% will need a chest tube at some point within 5 days. Okay, so if you have a pneumothorax, it's really like this is even including ones in trauma literature where it's like, oh, this person's going to OR. We know he has pneumothorax, but don't put a chest tube in, and majority of them do not ever need a chest tube or thoracostomy. All right. Under conjugate, inadequate resuscitating preload, because whoops. So please do not, this is a clean kill. Okay. There's very often that we intubate the patient before they're needed to be. And of all the intubations that we talked about, right? Failure to oxygenate, failure to ventilate, the only one that you can have to intubate immediately if their airway is actually obstructed. Okay, everything else I can get away with actually using a non-invasive positive pressure stimulation, right? And you say like, yes, that's still positive pressure, but you can actually have much less of it. The patient still has negative inspiratory pressure that can help you along with it without actually just killing the patient. Okay, make sure to adequately resuscitate before you intubate the patient and preload, especially when I'm going to discuss all the induction agents at that point. All right. The last one is RV failure or RV afterload. So again, unfortunately about this, the very quickly is that while the positive pressure ventilation will help with LV afterload and contractility, it actually worsens RV afterload and contractility. So somebody who has RV failure already and you see an ultrasound, and at this point, I mean, I literally, you guys don't believe this, about 12 years ago, I would not be able to say like, hey, well, on the ultrasound, if you see RV, half the people like, okay, sure, I'll do an ultrasound next time I work. You guys at this point probably done a couple hundred, I hope, at this point. So you know you should have an idea what RV failure looks like, right? So if you have that, be very, very careful. These are not the kind of patients that will intubate because they do not tolerate positive pressure ventilation very well. Make sense? All right. I think I went through everything. Any questions?